Hi, everyone. On today's podcast, we're going to talk about the evidence on the ARRIVE trial and elective induction at 39 weeks. Hi, everyone. Welcome to today's episode of the Evidence-Based Birth Podcast. My name is Dr. Rebecca Dekker, pronouns she, her, and I'll be your co-host for today's episode. Today, along with our co-host Morgan Richardson Cayama, we are going to be bringing you some brand new evidence-based information all about the ARRIVE trial and elective induction at 39 weeks. If you're listening to this podcast, you will also be able to access all of the information we're talking about, including references, a full-length signature article, and a free 2-page handout to help in your informed decision-making by visiting evidencebasedbirth.com/arrive. As a content note, today's podcast will include discussion about statistics on stillbirth and infant death and serious health issues for birthing families. Today we have with us Morgan, pronouns she, her, a doctoral candidate in public health and an evidence-based birth research fellow. Morgan, we're so happy to have you here. Do you mind just introducing yourself quickly for the audience?
Yeah. Thank you so much for having me again. My name is Morgan. I'm super excited to speak with you guys today about the ARRIVE trial and some of the other recent research that I've been finding on elective inductions at 39 weeks. And actually, alongside my work here at Evidence-Based Birth, my dissertation research focuses on something called respectful maternity care or respectful perinatal care. And so it's been really interesting for me to consider how the ARRIVE trial and induction relates to that topic, which we'll actually be talking a little bit more about later.
Yeah, and I'm excited. This whole podcast is an incredible wealth of information. But if you stick with us all the way to the end, we're going to get into some really interesting info about respectful maternity care that Morgan pulled up for us. So Morgan joined our team in evidence-based birth earlier in 2024, and she's worked on a lot of projects. She's helped update our pain management series, specifically the info about epidurals during labor and the effects of epidurals on the second stage of labor. So if you listen to our epidural podcast episodes this year, that work came from Morgan's research. She also co-hosted our spring webinar earlier in 2024, all about the ARRIVE trial. And so since that time, she's been working with me to develop a full-length signature article on the topic of elective induction at 39 weeks. Now, we did have a podcast episode on this subject. It was episode 10, released back in February of 2018. This was not long after we were dealing with the publication of the ARRIVE trial. And at that time, I wanted to talk about the findings while it was still hot off the press. We also published a 2-page handout at that time, which has been very popular. And we have since updated that handout. You can find it for free on our website at ebbirth.com/arrive. But still, 5 years or more later, we are getting so many questions about the ARRIVE trial. Questions from birth workers and families about elective induction at 39 weeks. And this study, the ARRIVE trial, has been the subject of so much attention and controversy. And there have been several new studies that have come out after the ARRIVE trial was published in 2018. So Morgan and I felt like it was important to put together a new comprehensive signature article, and it covers a lot of information. So for today's podcast episode summarizing what we're publishing, we've decided to focus on the key parts of this signature article, including what an elective induction is. We're going to review the ARRIVE trial and some of its criticisms. And we're going to talk about the updated evidence on elective inductions at 39 weeks. We're going to talk about the benefits and risks of this procedure, what the professional guidelines say, and we'll wrap up this episode with our usual bottom line. Again, because there is so much information, we do plan to have some future episodes on breaking down common questions we've been getting about elective inductions. And we also have a special episode planned about ways to lower the risk of cesarean for those who are interested in having a vaginal birth. So, Morgan, can you start us off, take us to the beginning of the article and tell us what is an elective induction?
Yeah, sure. So an elective induction is where labor is induced without any sort of specific medical reason, or you might hear a medical indication. So it's also sometimes referred to as a non-medically indicated induction. Elective inductions might happen for a variety of reasons. They might happen for social reasons, like a healthcare provider really wants to be able to attend a birth, and they might be going out of town, planning a trip, so they want to make sure that the birth happens before they do that. Or even a non-medical reason, like maybe someone is just ready to be done with a very uncomfortable pregnancy and they're, really want to have an elective induction. And so inductions are generally only considered to be elective when it is with a healthy birthing person who is pregnant with only one baby and who is less than 41 weeks pregnant. Otherwise, the induction might be considered medically indicated. And so if you kind of Google around or you search on the American College of Obstetrician and Gynecologists website, or ACOG, you'll find that elective inductions at 39 weeks are really only, again, recommended for healthy birthing people who are, again, giving birth for the first time and who are pregnant with a single healthy baby.
And, with that definition, it can be helpful to talk about some of the common ways that labor is induced. So we have natural methods, we have medical methods. So some of the natural methods that can be used to stimulate or try to get labor started include procedures like acupuncture or nipple stimulation or different herbal treatments. And we actually have a podcast series here at EBB and a YouTube series that we've done on this topic where you can learn about these different types of methods. And then we have medical methods of induction that are usually divided into two types: mechanical methods of induction and pharmacological or medication methods. So mechanical methods include the use of hands or medical devices. One of the most common is a membrane sweep. Now, a membrane sweep is not the most reliable way to get labor started, but it is an attempt to get things moving. Other mechanical methods include devices like cervical osmotic dilators, balloon catheters like the Foley bulb, and amniotomy or artificial rupture of membranes. And we've covered all of these on the podcast before, evidence-based birth. And then we have the medication or pharmacological methods. These include medicines like prostaglandin E1, which is often referred to as misoprostol or by its brand name of Cytotec. Then we have prostaglandin E2, which you might hear referred to by the brand names Servadil or Prepidil. And then we also have synthetic oxytocin, which you might hear referred to as Pitocin or Syntocinon. So when we talk about induction methods, they can be used alone or in combination with other methods. And combining different methods does tend to be more effective. Some of the methods I was mentioning help more with cervical ripening, where you're helping the cervix prepare for labor. And then some of the methods are better at starting contractions or strengthening contractions. Now, the alternative to labor induction is something called expectant management. Expectant management is often described as a wait and watch approach, where you're waiting to see, when will labor start on its own. We call that spontaneous labor when it starts on its own. With expectant management, if you're choosing this wait and watch approach, an induction still might eventually happen if you decide later that you would like to be induced, or if there ends up being a medically necessary reason to induce, like if there's a health issue or if the pregnancy goes past 41 or 42 weeks. Now, going back to elective inductions that are not medically necessary, we've personally seen and heard from many people about how common elective inductions have become over the years. And rates of elective inductions vary across different parts of the world. Even within regions, they can vary from hospital to hospital. And even in the same hospital, rates of elective induction can vary among the different healthcare providers practicing there. And we don't know for sure how many pregnancies are being electively induced, because in birth certificates, for example, in the United States, inductions are not always reported or recorded accurately. So we can't look at large data sets to see how many inductions are happening. But what we do know is that the overall induction rate, which is a combination of medically necessary plus elective inductions, is estimated to be about 30%. However, it's not uncommon to hear from healthcare workers and birth workers that they're seeing rates of induction that are much higher than 30%. We do know that elective induction rates have gone up since the ARRIVE trial was published in 2018. We'll talk about this more in depth later, but there was an excellent study published by Nethery et al. In 2023. They used data from 13 hospitals in the Pacific Northwest in the United States. They found that before the ARRIVE trial, the overall induction rate was 35%, and afterwards, the overall induction rate increased to 43%. And looking at the rate of elective inductions, that increased from 4% before the ARRIVE trial to 11% afterwards. In writing this article, we also looked at the international or global literature on induction, and we found that rates have gone up in many countries, and they do tend to vary geographically. However, most places around the world, the rates of induction are going up because of increases in medically indicated inductions. However, what we also found was that these increases were driven by increases in medically indicated inductions, not elective inductions. Outside of the United States, many countries are not recommending elective inductions at 39 weeks. And this makes sense for them because their health issues and their health systems are quite different than the United States. And many of these countries don't expect to see any benefit from elective induction. And so for financial and practical reasons, they are not recommending it. And so we should talk some more about the ARRIVE trial. Morgan, can you tell us a little bit about this particular study?
Yeah, absolutely. So first, ARRIVE, it's an acronym, and it stands for a randomized trial of induction versus expectant management. So researchers conducted this study because they wanted to compare elective induction in the 39th week of pregnancy to expectant management, or that wait and watch approach that you described earlier. And so the study was conducted between March 2014 and August 2017, and results were published in August of 2018 in the New England Journal of Medicine. And one of the big reasons that they did this study was because obstetricians in the US were conflicted about whether elective inductions at 39 weeks increased that risk of cesarean birth. And some older observational studies up until this point had found higher rates of cesareans among those who were induced. But these studies were kind of flawed in that they didn't always have true elective induction and expectant management groups to compare. And then later studies that ended up using some more modern research methods were actually beginning to find that maybe elective inductions had slightly lower rates of cesareans compared to expectant management. And so the researchers in this study, in the ARRIVE trial, conducted this large randomized control trial, and they were hoping that that would answer the question about elective inductions and cesarean rates. But actually their primary outcome, or the thing that they were most importantly sort of looking at, was whether elective inductions could lead to improved health for babies. And so again, that was their main focus. And then this look on the impact on cesarean birth and cesarean rates was kind of their secondary outcome that they were interested in.
Yeah. And so Morgan, before we dive deeper into how the study was carried out, I think it might be helpful to talk about the different perspectives or viewpoints on elective induction and kind of what was happening before the ARRIVE trial was published. So back in 2016, 2 years before the ARRIVE trial was published, ACOG, the American College of Obstetricians and Gynecologists, hosted a debate at their conference. The debate was called "Why Not Induce Everyone at 39 Weeks?" And I actually attended this conference virtually and saw this debate live. The debaters were both obstetricians, and they both took slightly different approaches to talking about the subject, but they ended up making the same argument that elective induction at 39 weeks was a good idea, primarily for the health of babies. And so this debate really only represented one side, that of people who believe that babies need to be rescued by making sure that they're born as early as safely possible. And the side that was not represented in this debate was the people who believe in letting labor begin on its own unless there's a medical reason to intervene. And so another way to describe these differences is the one approach is, why not intervene versus why intervene? And this perspective reflects a larger divide between the midwifery model of care and the medical model. So in the midwifery model of care, it tends to focus more on trusting people's bodies to give birth with minimal use of medical intervention. So you only use interventions if they're necessary or wanted. The medical model tends to view birth as inherently risky and recommends broad, sweeping use of interventions for everyone to prevent rare but serious complications. And so it should be said, talking about the medical model versus the midwifery model, there were no midwives among the ARRIVE trial authors. And even when Morgan and I looked deeper into the supplemental appendix from the study that lists all of the various staff and personnel from across the United States, we could not find a single person on that list who appeared to have a background or training in midwifery. This lack of perspective for midwives is important because midwives in many places have been impacted by this study and by the ensuing recommendations on 39-week elective inductions. For example, if midwives share clients or work with obstetrician colleagues, they're going to have to navigate differences of opinion and preferences for elective induction. And ACOG and then the American College of Nurse Midwives, or ACNM, have differing perspectives on elective inductions, which we'll talk about later. But overall, even though they said they were trying to see if elective induction was better, the belief that there were benefits to elective inductions was already pretty well established among OBs at the time the study was conducted. And so many of these researchers who came from the medical model may have had pre-existing biases about these benefits. Going back to that debate in 2016, they did a live poll where before the debate began, they found that 20% of OBs in the audience agreed with routine elective induction for everyone at 39 weeks. And that jumped to 70% of OBs at the conference believed that everyone should be electively induced at 39 weeks. So you can kind of see there's this underlying movement happening while the study is going on. So then going back to the study, Morgan, can you tell us more about how it was conducted and then what did they end up finding?
Yeah, sure. So the ARRIVE trial, again, was a pretty big randomized control trial, and it took place at 41 hospitals across the United States. And all of these hospitals were a part of something called the Maternal Fetal Medicine Units Network with the National Institute of Child Health and Development. And so that's going to kind of come into play in a little bit when we talk about how these hospitals might be a little bit different than other types of hospitals and sort of real world practice settings. But participants in this study had to be giving birth for the first time with a single head down baby and have no major medical conditions. So that's kind of what we consider to be called low risk. They also had to be eligible for vaginal birth and medically eligible to wait until at least 40 weeks and 5 days before giving birth. The hospitals also needed to have reliable information on the gestational age or the length of each participant's pregnancy. And overall, researchers across these 41 hospitals ended up finding about 22,500 people who were eligible to participate in their study. But actually only a little bit over a quarter, about 27%, agreed to participate. So they ended up with about 6,106 participants who again agreed to be in the study. The researchers then randomly assigned about half of those people, so around 3,000, to be induced selectively at 39 weeks, and then the other half to expectant management. And they did some comparisons across the groups and found that both ended up being pretty similar. And that's really what you want. You want two groups that are similar other than the thing that's happening to them. So other than the elective induction or expectant management. And both groups ended up being relatively young. The average age in the groups was 24. And they were both relatively diverse in terms of race and ethnicity. Births in both groups also predominantly ended up being attended by physicians, with only about 6% of births attended by midwives. And we'll talk a little bit more about that later too. So you can learn a lot more about these specific study protocols in our full-length signature article. But in short, those in the elective induction group had their labors induced between 39 weeks 0 days and 39 weeks 4 days. So the researchers in this study recommended that after they'd completed cervical ripening, birthing people be given at least 12 hours in early labor with synthetic oxytocin before being diagnosed with a failed induction and recommending a cesarean, unless, of course, there was an otherwise, immediate and medical need for one. And the people in the expectant management group had weekly follow-up visits with their care providers to monitor their pregnancies, see if any issues arose. And so participants in that group ended up having a mix of spontaneous labors, labors induced for medical reasons, and electively induced labors after 40 weeks and 5 days. And the reason this group was a mix of labor types was because of a research principle that the researchers followed in this study called intent to treat. And that's where you include everyone in their originally assigned group, regardless of what actually ended up happening or which path their medical care took. And we touched on this earlier too, but the main thing that they were looking at in their study again was the impact of elective inductions at 39 weeks on health issues for babies. And they looked at something that we call a composite outcome, and that's where you combine multiple outcomes into one larger one. So they looked at multiple serious complications and deaths for babies into this larger outcome. And so if any of these serious complications occurred, it was considered a poor outcome. And some examples of these included stillbirth or newborn death, intensive respiratory or breathing support, seizures, and low blood pressure that required intervention. And there's a list of some other things too that, again, you can find in the signature article. And then that secondary outcome, again, that they were interested in was that impact on cesarean rates. And so what they found was that electively inducing labor at 39 weeks had no impact on the primary outcome of death or serious complications for babies. However, they did look at some of those sort of individually, and they found that fewer newborns in the elective induction group needed respiratory or breathing support, although that was a pretty rare outcome overall. And newborns in the elective induction group also had shorter hospital stays. Only about 23% in the induction group had a stay of 3 or more days in the hospital compared to 27% in the expectant management group. But they did not find any differences in any of those other outcomes that they looked at. And again, overall for that larger composite. So looking at their secondary outcome or that impact of 39-week elective inductions on cesarean rates, they did see a difference between their two groups. They found that the risk of having a cesarean was 16% lower in the induction group. And although that does sound like a big difference at first, this represents something that we call a relative risk. And a relative risk is the risk of something happening to you in comparison to someone else. But if you look at something called an absolute risk between the two groups, you kind of get a bit different of a perspective. And it is important to consider both relative risk and absolute risk. And there's some mathematical formulas you can do to kind of get between the two. But if you look at the absolute risk or that true risk of a cesarean occurring in each group, that was 18.6% in the elective induction group and 22.2% in the expectant management group. So that's really only a 3.6% difference in that absolute or true risk of cesarean between these two groups. And so, yeah, there was a difference between the two groups, and elective inductions did have a slightly lower rate of cesareans, but it might not be as big or drastic of a difference if you hear that 16% difference in risk that some healthcare providers might present as well. So again, taking both into consideration is important. And they also looked at some other differences in maternal health between the two groups as well. So they found that the people in the elective induction group spent more time in the hospital in labor. And this does make sense because inductions can take several days. They tend to be some long processes. But the expectant management group ended up spending more time in the hospital postpartum. And that also makes some sense. And it might be explained by that slightly higher rate of cesareans that they did see in that group, which would, of course, require some more time spent in the hospital in postpartum in recovery. And then they also found that elective inductions at 39 weeks lowered the risk of developing pregnancy-related high blood pressure. And again, this is a finding that also makes some sense because the risk of high blood pressure does increase the longer a pregnancy continues. So it would be reasonable to see a higher rate of that pregnancy-related high blood pressure in the expectant management group. And so, Rebecca, you had mentioned earlier that the ARRIVE trial does have some limitations and it has been criticized a little bit. So can you tell us a little bit more about that?
Yeah. So as I touched on earlier, the researchers in this study who are running the study, designing it, carrying it out, came from a medical model perspective. And so they were likely a little biased in hoping to find good outcomes with elective induction. So normally what you would do in a randomized trial like this to control for your bias and to try and remove bias is you would blind or hide what is happening to each patient so that you can't influence the results. But with induction, it's impossible to blind researchers and doctors and patients to who is in which group because everybody knows who's being induced and who's not being induced. It's not something you can hide. So this makes it more likely that something called the Hawthorne effect can happen. This is a well-known effect in research and in everyday life that when people know they're being observed, they may change their behaviors. This may particularly happen if they know they're being watched and they know that outcomes are being recorded and that something important depends on those outcomes. So when you think about the secondary outcome of cesareans, deciding to do a cesarean is usually a subjective clinical decision that is highly impacted by physician practice patterns and attitudes. So if physicians were motivated to avoid cesareans in the elective induction group because they wanted to see a lower cesarean rate in that group, they could have acted consciously or subconsciously to try and prevent cesareans in that group whenever possible. And so because of this, it's possible that the cesarean rates we saw in this study, the low, 18% ish rate of cesarean in the elective induction group might not be replicated in real life situations if the doctors are not being closely observed and their outcomes being recorded. It's also possible that the hospitals participating in this trial are not representative of other hospitals. So remember, Morgan, you said that the hospitals were part of a special network. They consist mainly of teaching and academic hospitals. They might be more likely to follow stricter protocols and evidence-based guidelines in induction that we know aren't always followed in real life. And overall, the cesarean rate that you were talking about is pretty low compared to most hospitals in the US for first-time birthing people. And so there were other important limitations that have been written about. For example, the people who chose to participate in this study were willing to be randomly assigned to elective inductions. They might have already had more positive attitudes towards induction. And so the findings of the study might not apply to someone who's motivated to wait for spontaneous labor or who wants to avoid unnecessary medical interventions. So participants in the study also had different characteristics than the general population of pregnant people in the United States. For example, they tended to be younger and more racially and ethnically diverse in this study. And these differences are important because sometimes we see differences in the real world in rates of elective induction and cesareans based on factors like age and race and ethnicity. And you also mentioned that the vast majority, 94%, were receiving care from a physician. Only 6% had midwifery care. Today, about 12% of births in the U.S. are attended by midwives, and midwifery-led care has been shown to lower the risk of cesareans without needing to rely heavily on interventions like elective inductions. And then there were other important factors that we know can impact health outcomes and cesarean rates that were not measured or reported in the study. For example, we have no idea how many participants in each group received labor support from a doula. We don't know the different methods of pain management used by participants, and we don't know, which participants had continuous electronic fetal monitoring compared to intermittent auscultation, and then other factors that could lower the cesarean rate. Still, despite these limitations, the ARRIVE trial immediately got widespread media attention, and doctors very quickly began recommending 39-week elective inductions. And so, as expected, induction rates immediately began to increase in the US. And so this essentially created two time periods we can look at: a pre-ARRIVE world in the United States and a post-ARRIVE world. And so, Morgan, that was one of your big jobs this year, was to look at all of this research on the post-ARRIVE world in terms of cesarean rates and other health outcomes. So what has been the real life impact of this study?
Yeah, so that is a great question. And I have spent a lot of time looking into this research. And before we get into it, it is important to acknowledge some limitations. And so no research is perfect, and none of this research is perfect as well. And there are definitely challenges when it comes to comparing inductions and expectant management and studying this topic, again, because it is difficult to create those perfectly comparable and distinct groups. And although all of the more recent research on this topic is something that we call observational research, and it tends to be seen as a little bit, less rigorous or strong compared to randomized control trials like the ARRIVE trial, both randomized control trials and observational studies have their pros and cons, again, especially when it comes to studying this topic. Some of these new studies compared outcomes between all births in a time period before the ARRIVE trial was published to all of the births after, instead of, being able to compare or comparing inductions or elective inductions to expectant management. And so the goal of some of these studies was to look at all of these births and see if they did end up seeing changes in things like cesarean rates or health issues for babies since the study was published. And a good thing about these studies is that they can tell us a lot about the impact of the ARRIVE trial and sort of that unofficial policy of elective induction at 39 weeks. So for these researchers, they were saying, okay, if we know that we're seeing increases in inductions or we're expecting to see increases, let's do the research and see then, are we seeing things that we might expect, like reducing cesarean rates or reducing some of these health issues? And so that was the goal of a lot of these studies. Some of the other considerations about this research is that they, like the ARRIVE trial, were mostly limited to only low-risk birthing people who, again, were giving birth for the first time. This research is pretty U.S.-centric, and most of these studies were done in the U.S. So we ended up finding, I think it's a total of 8 separate studies, and you can definitely read a lot more about those in our full-length article. I'm just going to kind of go through and highlight a few here. So one of the studies that we included was done using hospital data that was collected at 13 different hospitals in the U.S. Pacific Northwest. And this study was done by Nether et al., and it was published in 2023, so pretty recently published study. And in that study, they did a time series analysis, and that's a validated way to look at changes over time and trends and changes in outcomes. And so they were looking at births in a time period before and after the ARRIVE trial. And they were looking for changes in rates of elective induction, unplanned cesareans, pregnancy-related high blood pressure, and again, serious health issues for babies, including NICU admission. They ended up comparing about 15,000 births from the year and a half before the ARRIVE trial was published to around 13,000 in that year and a half after. And what they found was increases in inductions and elective inductions across those 13 hospitals. But they did not see any difference before or after the ARRIVE trial in unplanned cesarean births, pregnancy-related high blood pressure, or NICU admissions. So some of those things that the ARRIVE trial found, they did not see in their 13 hospitals. There was another study that was published in 2023 by Wood et al. And in this study, the researchers used U.S. birth certificate data. So they had this big pool of birth certificates from across the U.S., and they looked at changes specifically in cesarean rates before and after the ARRIVE trial. And their study ended up including over 2.8 million births in that pre-ARRIVE period and 970,000 in their post-ARRIVE period. And they did find a decrease in cesarean rates, and they were able to do some analyses, and they determined that that decrease was lower than what would have been expected based on trends at the time before the ARRIVE trial was published. Can they definitively say it was because of the ARRIVE trial? Not necessarily, but those did decrease more than would have been expected. However, that change was pretty small, so it decreased from 25.1% in that pre-ARRIVE period to 24.7% in the post-ARRIVE period. We also included a study that looked at the impact of a pretty open and liberal policy of elective inductions at 39 weeks, and this was in one hospital in California. And this study was done by Jelks et al. And was also, again, published in 2023. And that hospital decided to explicitly permit 39-week elective inductions in their policy, and they pretty much left it up to the professional judgment of each of their healthcare providers to determine which of their patients would be good candidates for induction or elective induction. The researchers then compared the changes 1 year before and 1 year after that policy was implemented and their impact on induction rates and elective induction rates, cesarean births, and health issues again for birthing people and babies. Something interesting and unique to this study was that they actually did look at changes not only in those who were giving birth for the first time or who were low risk, but they also wanted to see if there were any changes or any impact on those who had given birth before or who were in different high-risk groups. And I'm not going to go into all of the findings because they do actually kind of split it up by these different groups, and it's really interesting to see. But essentially, they found that inductions increased across the board for everyone. So everyone was getting more inductions after this policy, and elective inductions at 39 weeks increased specifically for those in those low-risk groups. And so, for example, among low-risk birthing people giving birth for the first time, the rate of elective induction at 39 weeks increased from 6% to 28%. So that's a pretty big jump. However, rates of cesarean births did not change overall or for any specific subgroups. So again, seeing increases in rates of inductions, but not necessarily changes in cesarean rates. And so, looking at all of these findings across these and the other 5 studies that we included in the signature article, what did we find? And I'll try and summarize it here. So that main outcome that was focused on by the ARRIVE trial, again, was that impact on health issues for babies. And what we found was that the evidence was mixed. Only one study found a reduced risk of death or severe health issues for babies when they were comparing an elective induction group with expectant management. So they did find a reduced risk. Another study found no immediate changes in things like NICU admission or serious health issues for babies. But they did see a slight concerning increase in these health issues over time after the ARRIVE trial. And again, that was all births in that study. And then another study found higher rates of shoulder dystocia in their 39-week elective induction group compared to their expectant management group. But they found no difference for any other health issues. So again, that impact on babies is kind of mixed. While the ARRIVE trial did find that elective inductions reduced cesarean rates, we also found mixed results on this newer research about this. So as you could see from a few of the studies that I just summarized, some found no differences, and 3 studies that used data from hospitals found no decreases in their cesarean rates after the ARRIVE trial, but 3 very large studies that used data from U.S. birth certificates actually found some slight decreases in cesarean rates. And we do go into some more detail in our signature article about some of the limitations with birth certificate data, but that is something to note that those studies did find slight decreases in cesarean rates. The ARRIVE trial also found that elective inductions lowered that risk of pregnancy-related high blood pressure. And 2 out of the 3 studies that we found that measured this did find lower rates of pregnancy-related high blood pressure among those who were induced, either electively or medically. But another study found no difference. And so I would say, kind of putting this all together, that although we're absolutely seeing increases in rates of inductions and elective inductions at 39 weeks, the overall benefit is still uncertain. And again, electively inducing at 39 weeks does appear to be preventative for developing pregnancy-related high blood pressure. It's questionable about how much it lowers the risk of serious health issues in babies or lowers that risk of cesarean birth. And so, Rebecca, based on all of this research, I know that was a lot, and the ARRIVE trial findings, do you think it's reasonable to conclude or reasonable for someone to suggest that everyone should be induced at 39 weeks?
My short answer is no. The results from the ARRIVE trial and the recent post-ARRIVE research do not suggest that, quote unquote, everyone should be induced electively. I think that, it was really interesting hearing you go over the findings of the post-ARRIVE research, because what I felt like I was seeing after the ARRIVE trial came out is that this was like the promised land. We're going to have lower cesarean rates as a result of it electively inducing everyone. And the research is not showing that. It either has no impact on cesarean rates or maybe a very slight decrease, but it's not some kind of cure-all for the high cesarean rates in our country, and doesn't seem to have resulted in, the benefits they were expecting for babies. And what we still hear providers saying, this is better for your baby, even though the ARRIVE trial did not really show that, and neither did, we don't have confirmatory research about that in the post-ARRIVE period. So elective inductions might not lower the risk of cesarean for everyone, and some people might prefer to wait for labor to start on its own, especially if you prefer to avoid medical interventions. If you want to avoid the methods that I described earlier that are commonly used to mechanically or use medications to ripen the cervix or to start contractions. There are other medical interventions that are kind of typically packaged together with an induction, including frequent cervical exams, intravenous fluids, continuous fetal monitoring, and other things that can restrict your freedom of movement and your freedom of eating. A lot of hospitals have policies that forbid eating during an induction. And then these research results might not be applicable to you if you have midwifery care. As we mentioned, very few participants in the ARRIVE trial had a midwife, and having a midwife leading your care has been shown to lower the risk of cesarean without needing elective inductions across the board. Also, these research results might not be applicable to you if your care provider has a very high cesarean rate with their inductions. So it is possible. I think one of the cool things about the ARRIVE trial is that it showed that it is possible to keep your cesarean rate below 20% with an elective induction if the providers are motivated to follow best practices and to avoid unnecessary failed inductions. But not everyone follows these best practices. And so it's important, if you're considering an elective induction, that you know what your provider's cesarean rate is and you know what their cesarean rate is with elective inductions. And then, as you've mentioned many times, almost all of this research is on people who are low risk, giving birth for the first time, having inaccurately estimated due dates. So if you don't fall into that category, this research might not apply to your situation. And if you have a high-risk medical condition, you might end up needing a medically indicated induction. So, for example, if you have high blood pressure, gestational diabetes that needs medication, or if your water is breaking at term before the start of labor, those might be reasons to consider having a medically indicated induction. And all of this elective conversation doesn't really apply to you. Now, there are some, pros and cons, advantages and disadvantages to elective induction at 39 weeks that people might want to be consider if this is something that's being offered to them or they're considering having an elective induction. Some of the advantages include avoiding the complications associated with having a longer pregnancy, such as the increasing possibility of developing high blood pressure. An advantage is ending an uncomfortable or painful pregnancy. There may be benefits to scheduling an induction to accommodate having your preferred care provider at the birth, or if you need a specific family member present. It could potentially slightly lower the risk of cesarean if you're giving birth for the first time and your care provider is following best practices on induction. And it's possible that this could prevent rare cases of infant death or stillbirth. Though the research is mixed on this, the ARRIVE trial was probably too small to study this, and the absolute risk of stillbirth is very low until about 41 weeks of pregnancy. On the other hand, there are disadvantages or risks associated with elective induction. It's possible the induction might not work, and it might lead to what could have been a preventable cesarean. You are probably going to spend more time in labor with an elective induction than a spontaneous labor. You may experience a highly medicalized birth and a bundle of interventions that I mentioned earlier, such as intravenous fluids, restriction of movement, and it also might limit your access to some birth options you're interested in, like getting into a tub, having a home birth, or spending your early labor contractions in your own home environment. That might all go away if you elect an elective induction. And then medically induced contractions could increase pain and the likelihood of needing an epidural, although we need more research on that. And there is some research that suggests that induction and the use of multiple interventions bundled together during labor and birth can lower the likelihood that you'll be able to achieve your breastfeeding or chest feeding goals. So when we're making decisions about things like elective inductions at 39 weeks, it's helpful to consider the full range of options available, including the risks, benefits, effectiveness, and cost. And to know that there might be other options that are more affordable and less invasive than doing an elective induction that could lower the true risk of cesarean by a lot more than 3.6%. So you can read the full article and look for a table that describes all of those full range of options. And we're going to do another episode on that in a few months. So stay tuned for that. So Morgan, one of the last things I want to talk about is like your interest in research on respectful maternity care. Can you tell us more about what respectful care is and how it's related to the ARRIVE trial?
Yeah, so respectful maternity care is an approach to care that's really rooted in human rights. And that includes the right to make decisions about one's own body, the right to informed choice, and that right to consent about what happens to someone's body during their pregnancy, birth, and postpartum period. And it is an approach to care that's recommended by the World Health Organization and some other international organizations. And it is gaining some momentum here in the US as well. There's a lot more research coming out on this topic we're seeing here in the US. And with respectful care, we're not just concerned about achieving specific health outcomes like lowering cesarean rates or, having a healthy baby, but we also want to make sure it's also important that the birthing person's experience during labor and birth is positive and safe, that they feel respected, that they felt dignified during their birth. And so some key aspects of respectful care include care that maintains someone's dignity, respects their privacy and confidentiality, enables informed choice and continuous support during labor and birth, and is free from harm and mistreatment. And so kind of the opposite side of this, violations of respectful care are often referred to as mistreatment and obstetric violence. Obstetric racism is another term that you'll hear with this too. And so when I was kind of researching this topic and looking into the ARRIVE trial, I found that the ways that respectful care and mistreatment really relate to this really have to do with the way that induction is communicated with birthing people and whether someone has truly informed choice and uncoerced consent. These are really important principles for respectful care. At Evidence-Based Birth, we've heard from birth workers about the ways in which research like the ARRIVE trial and other research has been used to pressure and coerce people into interventions like 39-week elective inductions. And care providers might also tend to present biased or misleading information. They might talk about that benefit for babies that we haven't really seen. They might accuse somebody of not caring about their baby's health if they don't agree to have an induction. Or they might even attempt to perform an induction method like a membrane sweep without somebody's knowledge and explicit consent. So again, this is a very invasive procedure and not telling someone that they're doing this. And so all of this is considered mistreatment and obstetric violence. And again, just to reiterate, truly informed consent requires that healthcare providers provide full and accurate information to patients about the benefits of any procedure, their risks, and their alternatives, and accept and respect the patient's choice on whether to accept or decline anything that's recommended, including an elective induction. And something else to keep in mind is that inductions can really impact the way that care is delivered and someone's perception of their birth experience. So that includes how satisfied someone was with their birth and whether they even consider their birth to be traumatic. There is some research that has shown that birthing people who experience lots of interventions during their birth have more symptoms of trauma. And inductions specifically have been associated with less satisfaction in birth compared to spontaneous birth. And that all might be especially true for someone who does really want to be able to move and exercise their right to be able to move during their labor and birth or eat and drink. And again, even though these are rights that are owed to everyone, someone going through an induction might find themselves up against hospital policy or having to, advocate harder for those rights. And I also just want to reiterate that it is always the right of the birthing person to decide whether an elective induction at 39 weeks or any induction is right for them. That is a choice that you should be able to make for yourselves in following this sort of respectful care practice. In light of everything that we've talked about what the ARRIVE trial was and what they found and what other research has shown and the ways that that research might impact care, positively and negatively, what do the professional guidelines say, Rebecca, about elective inductions at 39 weeks?
Okay, so just quickly, we looked at guidelines published by several different professional organizations. You can access our summaries of those recommendations in the signature article. But something we found that was a common theme was that the importance of the birthing person's preference for whether or not they have an induction, which goes back to what you were talking about, Morgan, with respectful maternity care. But there were also some interesting differences in their recommendations. So ACOG states it's reasonable to offer a 39-week elective induction to a low-risk first-time birthing person, but they also note that care providers should consider staffing and facility resources to support inductions because they require longer labors, and that they need to have protocols in place to prevent failed inductions whenever possible. In contrast, the American College of Nurse Midwives generally discourages the use of elective inductions. They recommend that care providers practice shared decision-making and talk about induction risks, benefits, and alternatives, as well as the potential impact of an induction on the labor and birth experience. I found it interesting that in the United Kingdom, the National Institute for Health and Care Excellence recommends that low-risk birthing people be given every opportunity to go into spontaneous labor, and they really don't encourage elective inductions before 41 weeks. However, they say that care providers can offer membrane sweeps at prenatal visits after 39 weeks. They recommend that patients be told that an induction will impact their birth options and birth experience, and that care providers must respect any decision to delay, decline, or stop an induction. In Canada, the Society of Obstetricians and Gynecologists also does not recommend routine elective inductions at 39 weeks, although they do note that these elective inductions can be offered to people who are advanced maternal age, which they define as 40 years or older. So after all this information, what's the bottom line? So we know now that elective inductions at 39 weeks have become much more common in the United States, and that the ARRIVE trial is a big reason for this increase. The ARRIVE trial was meant to look and see if 39-week elective induction lowered the risk of death or severe health issues in babies, and they did not find this to be the case. They were also interested in the impact on cesarean rates, and they found that there was a slight decrease in cesarean rates with elective induction at 39 weeks, as well as a decrease in pregnancy-related high blood pressure. But this study had important limitations. The care providers and the hospitals in the study might not represent the average care provider or hospital. Very few people in the trial were cared for by midwives, and participation in the study was pretty low. This might be a sign that some people don't really want to be told what to do. They'd rather have the choice. And researchers running the study possibly had pre-existing biases about the benefits of elective induction, and they were eager to prove that it could lower the cesarean rate. Since the ARRIVE trial came out, studies have been published showing mixed results on the impact of elective inductions at 39 weeks in the real world. There is no strong evidence that elective inductions significantly lower cesarean rates or improve newborn health. However, there is more consistent evidence that it might lower the risk of developing pregnancy-related high blood pressure, so that might be something important to consider if you're at risk for that. There are benefits and risks and pros and cons to elective induction at 39 weeks. We've talked about those at length, but some people just prefer to end an uncomfortable pregnancy. Maybe they need to schedule their labor, and they might want to avoid some complications that might happen with a longer pregnancy. But some of the risks include that the induction might not work, and it either has to be stopped or end in a cesarean. It may be longer than a spontaneous labor, and there may be challenges with the bundle of interventions you need to go along with elective induction, including more monitoring and limited movement, hospital restrictions, potentially more painful contractions, and the need for pain medication. Elective inductions are not some kind of cure for lowering the risk of cesarean. Most of this research was done with a very specific group of birthing people who were giving birth for the first time and who were low risk. And the decreases they saw in the ARRIVE trial, as we've mentioned, were small in terms of the cesarean rate being lowered. So we really encourage people to have conversations with their care providers about the benefits and risks of elective induction. Remember that you have the right to unbiased and evidence-based information, and you have the right to choose an elective induction or decline one if that is what you prefer. So I just want to let you know that we have many resources at Evidence-Based Birth where you can go to learn more. If you want to dive down more rabbit holes or you just want to arm yourself with more information, we have an article about inducing for due dates. We have a podcast about Pitocin for inducing labor. We have a pocket guide to labor induction so that if you are needing or choosing an induction, you have all the tools you need to make it a better experience. And we have a full signature article on the ARRIVE trial at ebbirth.com/arrive, along with an updated 2-page handout all about this topic. So thank you, Morgan, for joining us this week.
Yeah, thank you so much. It was my pleasure.
It was great having you. This is a big splash for your first episode, and we're really thrilled you helped put this article together. For those of you who are listening in October 24, just a heads up that we will be taking next week off as a quiet week. We will be back on November 13 and 20 with 2 really important episodes all about the evidence on some newborn procedures. So I know a lot of you are going to really enjoy those episodes. So keep an eye out for all the new research coming out at Evidence-Based Birth next month. Thanks again, and we'll see you soon. Bye.